Angioedema, specifically upper airway swelling, is a potentially life-threatening condition characterized by rapid swelling in the deep layers of the skin, mucous membranes, and submucosal tissues. When it affects the upper airway, the throat, tongue, and larynx, it can obstruct breathing, leading to a medical emergency. This video will explore the causes, symptoms, diagnosis, and management of angioedema affecting the upper airway. The causes of angioedema are varied. One common trigger is allergic reactions to foods, medications, insect stings, or latex. These reactions involve the release of histamine and other chemicals that cause blood vessels to leak fluid into the surrounding tissues. Another major cause is medications, particularly ACE inhibitors, commonly used to treat high blood pressure. These drugs can lead to an accumulation of bradykinin, a potent vasodilator that can cause angioedema. Hereditary angioedema, or HAE, is a genetic condition caused by a deficiency or dysfunction of C1 inhibitor, a protein that regulates the complement system, leading to uncontrolled bradykinin production. Acquired angioedema can also occur, often associated with autoimmune disorders or certain cancers, again leading to issues with bradykinin metabolism. Finally, in some cases, the cause of angioedema remains unknown, termed idiopathic angioedema. The pathophysiology of angioedema hinges on increased vascular permeability. In allergic angioedema, mast cells release histamine and other mediators upon exposure to an allergen. These mediators cause vasodilation, increased capillary permeability, and subsequent fluid extravasation into the tissues, leading to swelling. In ACE inhibitor-induced angioedema and hereditary or acquired forms, the key mediator is bradykinin. Bradykinin acts on specific receptors in blood vessels, increasing their permeability and causing fluid leakage. The upper airway is particularly vulnerable because the loose connective tissue in this area allows for rapid and significant swelling, potentially obstructing airflow. Precise data on the epidemiology of upper airway angioedema is limited, as many cases may be mild and go unreported. Allergic angioedema is relatively common, affecting a significant portion of the population at some point in their lives. ACE inhibitor-induced angioedema is estimated to occur in about 0.1 to 0.7% of patients taking these medications, with African Americans at a higher risk. Hereditary angioedema is rare, affecting about 1 in 50,000 people. While anyone can develop angioedema, those with a history of allergies, autoimmune disorders, or certain genetic predispositions are at a higher risk. The signs and symptoms of upper airway angioedema can develop rapidly, often within minutes to hours. Common symptoms include swelling of the lips, tongue, throat, and face. Patients may experience difficulty breathing, shortness of breath, and a sensation of throat tightness. Other symptoms include hoarseness, difficulty speaking or swallowing, drooling, and stridor, a high-pitched whistling sound during breathing, which indicates significant airway obstruction. In severe cases, angioedema can lead to complete airway obstruction and respiratory arrest. It's crucial to recognize these symptoms promptly and seek immediate medical attention. Diagnosis of upper airway angioedema requires a thorough clinical evaluation. The physician will inquire about the patient's medical history, including allergies, medications, and family history of angioedema. A physical examination will assess the extent of swelling and any signs of respiratory distress. Laryngoscopy, a procedure where a thin, flexible tube with a camera is inserted into the throat, may be performed to visualize the larynx and assess the degree of airway obstruction. Blood tests may be ordered to measure levels of complement proteins like C1 inhibitor C4 and C-CUF, especially if hereditary or acquired angioedema is suspected. Measuring histamine and tryptase levels can help confirm an allergic reaction. Ruling out other conditions like infections or tumors is also important. While there aren't strictly types of upper airway angioedema in the sense of distinct disease entities within the condition, angioedema itself is classified based on the underlying cause or mechanism. These classifications impact treatment. We differentiate between histamine-mediated angioedema, typically caused by allergic reactions, bradykinin-mediated angioedema, resulting from ACE inhibitors, hereditary angioedema, or acquired angioedema, and idiopathic angioedema, where the cause remains unknown. Understanding which mechanism is at play is crucial for selecting the appropriate treatment. The treatment of upper airway angioedema depends on the severity of symptoms and the underlying cause. For mild cases, antihistamines and corticosteroids may be sufficient to reduce swelling. However, in cases of significant airway obstruction, immediate intervention is required. This may involve the administration of epinephrine, a medication that helps to open up the airways. Intubation, the insertion of a breathing tube into the trachea, may be necessary to secure the airway. For bradykinin-mediated angioedema, specific medications like C1 inhibitor concentrate, ecallantide, or icatibant may be used to block bradykinin's effects. Long-term management may involve avoiding triggers, such as specific foods or medications, and prophylactic treatment with medications to prevent future episodes. Prevention of angioedema involves identifying and avoiding known triggers. Individuals with allergies should carry an epinephrine auto-injector and be educated on its proper use. Patients taking ACE inhibitors who develop angioedema should be switched to alternative medications. For individuals with hereditary angioedema, prophylactic treatment with C1 inhibitor concentrate or attenuated androgens may be necessary to prevent attacks. Regular follow-up with a healthcare provider is important for ongoing management and monitoring. The prognosis for upper airway angioedema depends on the speed of diagnosis and treatment. With prompt intervention, most patients recover fully. However, delayed treatment can lead to severe complications, including respiratory arrest and death. Recent research is focused on developing new and more effective treatments for bradykinin-mediated angioedema, as well as improving diagnostic tools for early detection. Gene therapy is also being explored as a potential long-term treatment for hereditary angioedema. Ongoing research continues to improve our understanding and management of this potentially life-threatening condition.